strengths and many weaknesses of the profession from which I come. So thank you for those stories and for sharing them with us. When we get the slides up, what I want to do really is to go over some of what Rachel has just said about how to manage your GP.
Will you do the slide?
Oh, there we go. Yeah. Okay. Because I think we're on a species, I'm feeling a bit nervous because I'm in a room on my own with one person and I only have 10 minutes to talk to them. So I think I've got lots of you here and I've got more than 10 minutes. But you do have to manage your consultations with people. I think whatever your company you're in, but perhaps, especially in the NHS where things are very busy. So the first part of what I'm going to say is about how to use the service and how to empower yourself service and get the information you need about PCOS. So the first thing to say about your GP is get to know what kind of GP you've got. All right, they're very variable. They vary in age, and they vary in interests, and they vary in terms of how much they bite or are nice. Typically, just to give you an perspective on what they'll have done, 5 years as a student, they might then have done a job, during their student, they might have done psychology with more or less interest. If they're going off to be an orthopedic surgeon, they may not what they think they are, they may not be that interested, but they'll spend sometimes doing ops and gynae. And they'll have done about 12 weeks of general practice during their training. After qualification now, which is very good, it didn't used to happen, they will do about 4 months in primary care. So during the first 2 years after they've trained. And then if they're going to be GP, they'll do probably another 4 or 6 months of gynecology or community gynecology during that training as well. Perhaps some dermatology along the way. And then they'll spend about a year as a specialist trainee in general practice. After that, it's up to them really what they do, depending on their interests and depending on where they feel their weakness is. So again, very much up to the individual how much information they have. So I think you can characterise GPs as young and enthusiastic. Okay, they will be up to date with the science, hopefully. PCOS is now taught on medical curriculum. I wasn't taught anything about it 20 years ago, but they should be fairly knowledgeable about the science. At George's, we've got great people like Sue Ryan teaching medical students about the basic science. They might be very specialised, and a lot of women do specialise in women's health, so may know quite a lot about PCOS and gynecology. But your GP may be a musculoskeletal interest person and may know very little about PCOS. So you need to find out what their interests are. And then finally, they vary in experience. So people may be a bit sort of grey like myself and have a lot of years' experience, but may not be very specialised. So get to know, just talk to your GP and just find out what they enjoy doing. Now, the advantages of working with your GP is that they know you, they know what else is going on with you, don't they? They sort of know any other issues, health issues you might have. To see them when you want, every 2 weeks, weekly, if they're going through a particular crisis, it's up to you to book the appointment. You've got other people within the practice, so nurse practitioners and practice nurses who might have more time for you as well. And we very much try and pride ourselves, although perhaps not according to the experience of some of you or Rachel, perhaps in terms of their communication skills and ability to be patient-centred. That's what we aim to be. In terms of secondary care, it's very pressed, and you will get hopefully an expert opinion about your condition, but it'll be in very small amounts of time. They're less well set up for information giving or explaining conditions as well. Though occasionally you can get very good nurse specialists in particular specialties who will have more time to explain things to you. And they tend to pick and mix on what they do. So, with PCOS, you may find that you end up seeing a dermatologist and a gynecologist and an endocrinologist as well, as I'm sure some of you will have had experience of in the past. So they're not very good at integrating their care, and you end up having to go and see lots of different people. So for people with PCOS, I would try and sound out your GP. There will usually, almost certainly in most practices, be somebody who's interested in women's health. Interested in women's health and who will know a bit more about PCOS than other people. So younger GPs will be better with the science and target those who you think might have an interest. And they'll often be the people doing family planning or coils, things like that in practice. The next thing is have a think about how good your GP is. And don't stay with them if they're not very good. Okay? If they're burnt out, tired, you know, break down in tears in front of you when you're seeing them, they're probably not working very well. Okay? So, you know, don't put up with them. Change your GP. Go and see somebody else within the practice. Do they listen to you? Do they take a proper history from you about the impact of whatever your condition is on your life? Do they examine you? For me, that's a really crucial thing. You know, GPs who are stuck at the computer, scribbling prescriptions on there and never actually examining you when you've got a cough or whatever the symptom might be. That's not a good GP in my book, really. A very gross way of telling whether or not they're good is whether they have trainees or medical students, because we organise GP training in South London and George's, and we don't let practices teach unless we think they're good at teaching, they're knowledgeable, and they're going to give those students a good experience. Similarly, you may come across GP trainees who are there, and again, the practices are, you know, people come and visit and have a look and just make sure that they're okay. And then finally, can I get to them? Okay, it's no good having a GP who's brilliant, but you can't see them for 4 weeks. So you need to be able to access them. And I think as a profession, we're getting better at the access, really. We still haven't got email access set up in our practice because there are complications about how to do it. We get very nervous about people with emergency conditions emailing us and nobody gets back to them and they're having a heart attack at home. But we're trying to grapple with that and work out safe ways that we could have email communication with our patients. And you know, something like PCOS where you might have queries along the way, that would be a very helpful thing to do. Okay, so sometimes, you know, your GP is going to be fantastic, and these are the sorts of things that I have conversations with patients about. So obviously we've talked about diagnosis and heard people's experiences of that already. Obviously period problems. Sometimes people have got other symptoms and don't know whether it's their PCOS, if they've already got a diagnosis and not sure about that. Obviously fertility issues, weight issues, hair issues. As well. The sorts of services that we have in primary care are the services we have for every condition that can be tailored for people with PCOS or issues related to PCOS. So in my locality, I can refer people for cheaper exercise, access to exercise, who have particular conditions. So they can go and get cheaper swimming or cheaper gym membership in the locality. I can do that for them. We've got a dietitian at the practice. Obviously, we can provide skin care or make referrals for skin care if that's appropriate. Chronic disease monitoring, so for people with PCOS who might be at risk of getting diabetes in the future, we can arrange annual monitoring for that as well. Obviously, we prescribe for any condition. We always consider mood issues and might manage that as part of the condition that somebody's got. And because we've got a registered population, we can have a list of people who we will call up to do things that we think they need for their health on a regular basis. So all of those things might be relevant to somebody with PCOS. So how to tame your beast? Okay, hopefully you've got a nice communicative GP that gives you time and listens to you, examines you when you go and see them. But be aware of the pressures they're under. All right, we would love 15-minute appointments. Very few practices manage to do that because we have to promise to offer 3.5 appointments per patient we have registered per year. And the only way that we can do that and get home at 10 o'clock at night is to do 10-minute appointments in our practice. We physically can't do it with longer appointments because we just don't have time of the day to do it. And we're contracted to offer that many appointments. So it's difficult. Having said that, I always run late because I always spend more than 10 minutes when people need it. So my patients will be sitting there glumly with concrete bottoms in the waiting room. So we do try and be flexible according to what people need. But be aware that your GP is going to be under pressure and that if you take more than 10 minutes, the next patient may make a complaint about that. The GP is running behind. So strategize, okay? Empower yourself before you go. Have a look at information that you need. Think about what questions you want asking. If allow you at the practice, and I tell people to do this, book a double appointment. If you know that you're going to need an examination, if you've got a couple of issues related to your PCOS you want to do, see if you can book a double appointment and just be honest and say, I think this is making think about asking for written resources. I'm going to show a couple of those in a minute. Communicate with your GPs. I think email is on the way. It will be there in a couple of years. We'll have safe ways of, communicating with people. But just leave a message for your GP and they're going to get back to you. Okay? You don't need to see them. Just leave a message and say, can I just ask them about my metformin or my tablets or whatever it is, and they will phone you back. They should phone you back. And finally, writing letters is very good as well. So there's lots of things we use. Website on the NHS website called NHS Choices that has lots of really good information. And this has kind of come on board in the last couple of years. It's now a very rich resource that I use all the time in my course, not just for PCOS, but for other things. They've got embedded videos and pictures and people talking about PCOS. So that's a good one, NHS Choices. And there's another one called patient.co.uk, which again, for any condition, and again has very good written resources that will give you, information as well. So these are all freely accessible on the net. And then this is the sort of thing that your GP is taking a look at when you think that they're prescribing something for you. Something called GP Notebook, which does rely on a bit of science knowledge really to kind of understand what it's saying. So it is quite technical. You can I think 3 pages, I think, before it shuts. Okay, but sometimes your GP is not going to be able to manage your situation, and you might need a referral. So just to be aware of what the processes are around referrals, you need to come to a shared decision with your GP at the time. So have that conversation with your GP, listen to them as well as what they've got to say, and think what you specifically want. Sometimes it can be very clear, the GP is anywhere, and you need to actually at that time pull in the next alert. It's very clear what the referral will be. A system called Choose and Book. You have the freedom to choose where you go to see a specialist. So this is where it's really important that you GP to do a bit of groundwork, because your local gynecologist, your local dermatologist may not know much about PCOS. Okay, and that's work that your GP can do, but you can do. Most have web pages that show what their special interests are. So you can do looking for the gynecology services and then looking up the consultants to see who they are and what they're interested in. And anyone with an interest in this area might well pop up with some published papers on clinical work. Verity got a very good list of who's good locally across the UK as well. You need to do some of that as well. It's much easier for them to do it than it is for you. Theoretically, ought to allow you to be referred anywhere. Sometimes there are restrictions about where you can live. Theoretically, it's set up that we have somebody in Stornoway, Scotland, if I thought that's appropriate. But sometimes, because of the way that contracting works, groups won't let you do that. So very occasionally you have to make a case. But there ought to be some expertise in PCOS. I would say they're 30, 40, 50 miles away from the UK. But as I say, Verity might have a good resource around that. The other thing to remember is if you do see something is that you've got a right to a second opinion on the NHS. And lots of people don't know. Go back and redo your spade work about who you want to see, or ask around, or ask Verity, and then ask for another referral to go and see somebody else. And in terms of obtaining your consultants, really, the same things apply as they do to GPs. People are starting to audio tape consultations now, and I'd really, you can do that on your phone. Just ask the GP if they might, or the consultant if they mind. If you just, tape the consultation. I don't know what the word is. Digitise the conversation there. So that you've got a record of what was said, because it's very hard to take in stuff. I'm really bad at this thing. It's very hard to remember everything when you're there and you've got your 10 minutes and the consultant's flapping in and out to go and see some trainees and things. So take it and then you can go back and listen to it later. And again, use all those different methods of communication with your consultants as well. Their secretaries are very useful. If you've got something you don't understand or that scan that they've ordered that doesn't happen, just go to your phone on the switchboard, ask for Mr. So-and-so or Mrs. So-and-so's secretary, and speak to the secretary directly. I'm expecting this and it hasn't happened. So a lot of are emailing patients as well. I think all, as I said before, that's a bit of a ride for us because we don't quite know when we'll reach saturation point in terms of how many people we can keep in touch with. People want to, very happy to use the media, but there are operational difficulties about managing. Okay, so that's about the service and how to get the best out of it. I think there's some time for questions.
There is. Thank you. Yep. Thank you very much. So please wait for the microphone to come round to you. If you are too shy to ask a question, you can write it down on a sticky note and hold it up, and one of the ladies at the back will come and grab it and ask it on your behalf if you like. But do you have any questions about how to utilise your GP or consultant? Yeah.
So if you've been discharged from seeing a consultant, I was discharged probably about 15 years ago, how can you take that up again if you feel you need to?
So you just need a re-referral, okay? Consultants are brilliant at discharging people at the moment. They just try to get rid of people all the time. I had a battle with the manager yesterday with somebody on a very surgical waiting list. They just wanted to get rid of this neurosurgery, this person. So you just need to be re-referred. We just bat and forth between GPs and consultants about getting referrals. But typically what they do nowadays, in the old days when I trained, they would keep somebody on their books and see them every year. To be honest, that often wasn't very useful, use of time for anybody. So what they would try and do would be to keep people on their books for as long as they felt that something useful was happening. But if people kind of go up and down in terms of their needs, but if they kind of episode of care needed finished, typically they would discharge you with instructions to the GP about what to do. But if something else, becomes important, then
kind of opposite end of the spectrum, I've got my first appointment with a consultant next week, and I suppose it would be really good to get your advice on what questions should I ask. So it's about fertility that I'm going to see somebody.
Right, okay. So obviously that's very dependent on what your situation is. What your personal situation is. Are you going to see a kind of assisted conception unit, or is it a gynecologist? Or
a gynecologist.
Gynecologist, okay. So, what I would do is think about what the 3 or 4 questions you've got that are most important to you might be before you go. And I guess those might be things like, why do you think there might be difficulties in me conceiving? Can you explain it to me as it relates to myself? And then what can be done about the situation that I'm in? When I get people to go to consultants and they're considering intervention, be it surgery or not surgery or tablets or anything, I say to people, ask the consultant, what would be likely to happen to me if I don't have the treatment? So if I don't have any treatments or don't do anything, perhaps in this case, what would be my chances of conceiving? And if I do have this, this particular treatment, what would be my chances of conceiving? Okay, so if I do nothing, what are the benefits? And then the other important question is, what are the hazards? Okay, so for surgery particularly, you might might get a 50% chance of improving something. If that's got a 90% chance of killing you, you might not choose to do it. All right, that's not likely for a fertility clinic, but it's an important question to ask all the time. The other question I think is really important to ask is how many patients like myself do you see and treat? Okay, and again, that comes back to, is your clinician familiar with PCOS and people like you? If they're talking about surgery, probably not what you're contemplating possibly, but you know, it's very, very important that you say to the surgeons, how often do you do this operation in people like me? And you know, what's your success rates and what are your complication rates? And people do audit that kind of thing, particularly in surgery, so should be able to give you data like that. So for example, at George's, we've got a heart unit, and they publish on the net actually their patients they see, what they do, and has a breast split is also what the complication is. Does that cover it? Yeah.
I would like to ask whether it's possible for a consultant to refer to another department within the hospital, rather than referring you back to the GP, who doesn't always agree with the consultant.
Yeah.
With regards to, you know, what the original consultant said is needed, for example, for gynecology to endocrinology or something.
I think there are local agreements about that, I would say. The trusts I work with, they seem to do both, I would say. So some consultants seem to be able to refer to another consultant within the trust. Sometimes we get a letter back to us saying, please can you refer to X, Y, or Z. And you know, sometimes we don't agree with it. I mean, we've got a longitudinal record of patients. I'm not talking about PCOS here. Often we know that that patient's already seen somebody in that specialty a year ago, you know, the outcome of that. So that would be the kind of reason why we like it.
Who's got the final say on that, though?
I think you
Oh,
okay. So I think the bottom line of what I'd say is you know, it's just be reasonable. So listen to what your GP's got to say, listen to what your consultant's got to say. But my personal experience of, you know, managing family members with health problems in the NHS is that friendly assertiveness goes a long way. And I would encourage you all to be assertive. Okay, so if you've got a genuine need that's not being met by the services that you've encountered already, be friendly assertive about making sure that you get it. You know, if you're asking for something that doesn't exist, that's a different thing, or a solution that doesn't exist. That sometimes people have expectations that can't be met. Generally, you know, it's just not, just keep asking. And don't forget about your right to a second opinion.
I haven't been to the doctors for about 3 years because I gave up with my doctor, but I moved up to Manchester about a year ago and I've yet to register with a practice up here. What would you advise me to do? What would you advise me to say when I register up here?
Do you mean in terms of choosing a practice, or once you've actually registered?
Choosing and once I've registered as well.
Yeah.
It's not ideal coming in with.
So you know, if somebody with PCOS registers with practice, I think I'd want to find out about what they do about that list of things that I said that GPs can do really. So do you have a dietitian? Can you refer me for any, if you're interested, this is if you're interested, you know, are there any opportunities for exercise on referral schemes locally? How are you going to monitor my risk of diabetes in future? How often are you going to see me? You know, do you have anybody who's got an interest in skin or in women's health and things? I mean, I think the crucial thing is you find someone that you get on with. Okay, I work with a partner who sees people in about 3 minutes. A lot of patients like that because he's always on time and very bright and he's very good and he does things very quickly. I'm, you know, a bit chatty, as you can tell. So I spend a bit longer with people. So I think the crucial thing is that you've got somebody that you feel is going to be your partner and walk with you on your journey through whatever your health issues are. So that's a crucial thing. And then access to services and asking those questions.
Do you have to go to a surgery that's in your area? not sure how that works.
So at the moment, it's just about to change. Just to change. I think practices. I think what's happening in home care is that practices are trying to become more sustainable by getting bigger, really. So I think practice areas are going to get bigger than they are at the moment. Generally, you've got to do somewhere near, because at the moment we're actually obliged to visit people at home if they need it, so we can't have people registered too far. The government, they become hopefully suggested very quickly that that boundary issue should change so that you can register anywhere. So you go and see a GP and they wouldn't be required to visit you. But you can see that there are enormous complexities about that, because then what happens to you when you need healthcare at home at night? You know, who's going to be doing that, and who's going to be paying you that? So they've had to put it off. It's supposed to start on the 1st of October, that you could register somewhere away from where you live. It's been put off now until I think about February. I really don't have any solve the complexity of doing that with the home history. So probably it will have to be somewhere near where you live at the moment.
I just wanted to ask the floor, really. I've now found a GP who's actually been quite helpful and sort of kind of lets me, I go in and tell her what I've been doing, basically, and she lets me get on with it, which is really, really helpful. But am I the only person? And I know there's some brilliant professionals out there, and I'm not having to go at the entire medical profession, but has anybody else been told repeatedly that they're just making it up? Because I feel like I'm the only one, and that's, you know. Okay, thank you.
I think that's a common experience.
For example, this lady is the only female doctor in the practice. I live in a rural area, so I have no choice of practice. That's me. That's the one I go to. And I'm prescribed metformin. I've experimented with different dosages and taken myself off it, and it's quite clear that things are a whole lot better on it than off it. I had a review with her in May, and then just the other week, another doctor decided he wasn't signing off any more metformin for me because I needed a blood pressure check, which is ridiculous. He had no history, no knowledge, and he just decided to stick his oar in. Yeah, he got the wrong side of my tongue.
I mean, I can also remind you that there is a practices.
Maybe I should. Yeah.
So again, my experience with companies is that sometimes an assertive, nice letter suggesting how people might improve their services is helpful as well. They take up enormous amounts of our time and don't necessarily really don't like getting. So that's a great motivator to take on board. But a letter suggesting that actually, stopping someone's medication isn't going to help anyone, is it? Just to drag you in for your blood pressure check.
And it was bonkers because she'd done it 3 months earlier. She was clearly so worried about it. I've never had a blood pressure problem. Yeah. It was exactly the same as it's been for the last 20 years. She obviously wasn't worried. Yeah. So it just took up time in the surgery that wasn't really needed. Yeah. So, the people who really worry about are those who've got really bad blood pressure who don't come in. And those people, very occasionally, if you phone them up, register them, and still don't come in, then you might think about stopping medication. That seems very
Hi, my question's related. So my GP also prescribed metformin and said after initial bloods, go away and see how that works for you. But I guess there was no kind of suggestion for a viewpoint or the way of tracking whether it's working out based on my own symptoms. Do I, as a patient, have I guess the authority to go back and request bloods to kind of check progress and review?
In terms of your predisposition to diabetes and screening for that, there's nice guidance about how that should be managed. So anybody who isn't handling their sugars very well and is on the way to diabetes, there's a protocol that GPs should be following. I think for anyone who's not in that category, but just taking that form in, I'd have thought a clinical review with the GP to see how you're getting on. Would be really important. We can just put that up and explain that that's really important. One thing I would say about metformin, people who are taking it is always, what I always do is really start with a low dose so that you don't get the tummy upsets that it can give you. So I find that if people start low and build up very slowly, they're much more likely to stay on it and be able to tolerate it. And people who push on a big dose straight away.
And so how often do you
I think it depends what the, I think it depends what the problem is or why you're taking it metformin. So if somebody had period irregularities, for example, I'd want to be reviewing that and knowing that they weren't having regular periods and doing something about it if they weren't. So perhaps, I don't know, 6 monthly, something like that, depending on what the history was really. That's a bit sooner if they've not had periods for a long time. Again, that's a kind of action planning that would be within our 10 minutes we'd like to get out of. Okay, this is a plan, let's start this, have a telephone consultation in a month's time to see how you're tolerating the metformin, and then let's see what impact it's had on you in 6 months' time. Okay, so that should be the end of your consultation.
Other questions?
I would like about to know on the symptoms made me really ill. So
it's just being very clear.
And made me really ill. My GP just said I'm not taking as we can do. Not the minutes and say.
Okay, and what dose did they start you on? Just like 500, yeah. Okay, so some people don't tolerate it because it can give you, upset tummies. Pardon?
Since then, I'm sorry.
Yeah.
You just hold the microphone up.
And since then,
Right. What I would say is, just always go back and retrench, really. So if you're taking it daily and you want to take it, I might say, try taking it every 3 days. Once you're tolerating that, go up to every 2 days and then every day. See if you can just build up tolerance like that. The other thing when you're on a bigger dose is that sometimes people are on a slow release metformin have fewer of the side effects. So that would be the other thing that I would Oh, right, well, that's, you did well. They don't feel globally horrible. Yeah. The other thing to do is think about dropping the dose a bit and just seeing if a lower dose, if you don't feel so horrible on the lower. Right. Yeah. So have a think about. And 1,000 for a month or a bit longer, depending on how you're doing before getting it. Okay.
If I may say, we'll talk about metformin later on as well, what you might expect and what you might not expect with metformin, how to manage too many problems or something about it as well. It's complicated.
Other questions?
Okay, well,
Thank you.
Coffee if you want to ask me questions.
Thank you very much.